The biggest controversy in terms of diagnosis and staging Alzheimer's disease really arises from the fact that there are two separate diagnostic paradigms that are floating around. One is the Alzheimer's Association, the other is the IWG. And I guess and obviously I represent the Alzheimer's Association point of view and in this controversy. And one of the things that will arise from this afternoon's symposium, hopefully, is that people will, so there's a big controversy. The IWG defines Alzheimer's disease as a positive biomarker plus symptoms. The Alzheimer's Association defines the disease as based on its biology, based on a positive biomarker. And so when the disease is first detectable and should be called a disease, there's a big time difference there. For the Alzheimer's Association, it is probably 15 years prior to when the IWG would say someone has Alzheimer's disease. That 15-year gap between the onset of biomarker abnormalities and onset of clinical symptoms, the IWG would say that person's at risk for Alzheimer's disease. They don't have Alzheimer's disease until they have symptoms. The Alzheimer's Association would say no, the person has the disease. They are at risk for developing symptoms from a disease they already have. Now, my take on this, obviously I have a biased perspective. My take on this is the following. Imagine two different people, and I'll say this in the presentation this afternoon. Imagine two different people. Both are at stage A, so the initially detectable stage of Alzheimer's disease in the brain. For argument's sake, let's be very clear. They have a negative tau PET scan, positive amyloid PET scan. Let's imagine the amyloid PET scan is an identical centiloid value, 35, 40, clearly positive, no question, but mildly positive, completely consistent with a negative tau PET scan. Now, the Alzheimer's so both patients, that they're in stage A, and that's their situation. But one is asymptomatic. The other person has mild dementia. Now, the Alzheimer's Association would say the first person who's asymptomatic, that clinical stage matches the biologic stage. That's what you would expect. The second person, there's a clear dissociation. Alzheimer's disease, given the stage, cannot explain that person's cognitive deficit or cannot explain that person's biological stage or clinical stage. Therefore, the second person has to have a second pathology or a third pathology, non-Alzheimer's pathology that's driving symptoms. It's a very rational way to approach it, right? What would the IWG say about those two people? The IWG would say that the asymptomatic person is at risk for Alzheimer's disease, whereas the second person has Alzheimer's disease because they have symptoms. But stop and think about it. Does that make sense? There's no difference with anything to do with Alzheimer's disease between those two people. The only difference is the second person has late or microinfarcts. So in other words, the IWG is using late disease or microinfarcts to define what is and what's not Alzheimer's disease. Does that make sense? Sorry, to me it doesn't make any sense. And to me, where's the logical flaw fall? The logic flaw falls because the IWG uses a non-specific entity, clinical symptoms, to define Alzheimer's disease. Symptoms have never been, a lot of things can cause symptoms. Alzheimer's disease is one of them. But so can late, and so can microinfarcts, and late is not Alzheimer's disease. Microinfarcts are not Alzheimer's disease. So to me, and I'm not trying to again, hope this doesn't come across that I'm trying to run down the IWG. I'll say this afternoon, I'll say it right here. I mean, for example, Giovanni Frazzoni is a big advocate of the IWG. He's a member of the group. He and I have been friends, colleagues for years. So I'm not trying to run down those criteria. What I want to do, though, is emphasize what I consider to be the scientific precision of the Alzheimer's Association criteria, particularly the staging, integrated clinical and biological staging, which I think, correctly as well as we can do it now, since there are no biomarkers for late disease, there's no plasma biomarker, for example, for alpha-synuclein, etc. I think identifying these discordances between clinical and biological stage right now is the best we can do in terms of correctly categorizing and thinking about people at an individual level. And I'll just say this, in the context of this afternoon's symposium, you see the same pattern of thinking evolving in other neurodegenerative diseases. So the idea that the disease should be defined by its biology and staged by biology plus clinical symptoms is not unique to Alzheimer's disease. Experts in other neurodegenerative diseases are thinking exactly the same way.